speaker tonight is Dr. Stevens, who's a consultant urologist at the Princess Margaret and Doctors Hospitals. He's a member of a number of organizations, including the American Urological Association, Endo-Urological Society, and the Caribbean Urological Society. He has a keen interest in genitourinary malignancy. And tonight he's gonna help us bust a few myths about prostate cancer and give us some tips that we're gonna share with all the men in our lives who aren't on the call with us today. So over to you, Dr. Stevens.
I'm a urologist. I work at the Princess Margaret Hospital. Now, today we'll be speaking on prostate cancer. And as you may be aware, September is prostate cancer. It has been designated Prostate Cancer Awareness Month. And on this day, we focus on the number 2 cancer in men, only second to lung cancer. And we will seek to learn about and support men living with this disease. And as I go along, you will realize that the health burden from prostate cancer is indeed great. Okay, Okay, in terms of the extent and distribution of prostate cancer, it is estimated that 1 in 8 men will get prostate cancer in their lifetime. As I said before, it's the second most diagnosed cancer in men worldwide, according to statistics from the World Health Organization in 2020, only second to lung cancer. It is the number 1 diagnosed cancer, however, in men in the Caribbean and over 50 other countries. The highest incidence of prostate cancer is seen in Northern and Western Europe and the Caribbean. And the lowest incidence is in Asia and North Africa. It is noted that the highest mortality or the highest death rate of prostate cancer is in the Caribbean, at a rate of 27.9 per 100,000 persons. Now, I don't know if this chart is projecting well, but just showing you the Caribbean in the 3rd position. The blue is the incidence and the red is the mortality or death rate. As you can see, the Caribbean is 3rd in incidence according to the 2020 statistics. But if you look at the red on the right-hand side here, you will see that it has the greatest mortality of all the other countries. Now, in terms of incidence, approximately 1.4 million men had prostate cancer in 2020. And this incidence chart shows the Bahamas at position 10 in terms of the number of new cases that occurred in that year. In terms of the death rate, the Bahamas sit at number 7 in the world, okay? Other Caribbean countries are also quite prominent, with Barbados being at number 2 and Jamaica number 5, of course Haiti 3, and Trinidad and Tobago 6. So the burden of disease in the Caribbean is indeed great. Now, one may ask, what are the causes of prostate cancer? And, you know, there are some risk factors that we have identified that increases your risk for prostate cancer. Age is one of the prominent ones. Prostate cancer is rare before the age of 40 years. And 6 in 10 men over 65 years, prostate cancer occur in that age group. In terms of ethnicity, the highest is in persons of African descent, with an incidence of 1 in 6. The lowest is seen in the Chinese population. And when it occurs in persons of African descent, it is more likely to occur earlier and more likely to be aggressive. And you're 2 times likely to die than your Caucasian counterpart. Family history is also very important. If you find that your brother or your father has prostate cancer, your risk increases 2-fold. You're having a grandfather who also has prostate cancer also increases your risk. But not only prostate cancer in family members is important. Family members with ovarian, breast cancer can increase your risk for prostate cancer if they share a certain gene that is also shared with prostate cancer. It's called the BRCA1 or BRCA1 and BRCA2 gene. BRCA2 gene tends to be the one that gives a higher grade cancer and poorer outcome. So if in a family history there's breast cancer and ovarian cancer, it behooves you to check on your prostate. Now, persons are always asking, how can you prevent prostate cancer? Unfortunately, we don't have any single thing to say, yes, take this and it will prevent prostate cancer. We have not reached at that level as yet. But studies have shown that lifestyle modification can indeed impact on having prostate cancer, as well as if you have it, reduces the aggressiveness of prostate cancer. So most of the studies clearly show that a diet rich in fruits, vegetables, antioxidant micronutrients may significantly reduce the risk. Things like smoking increases your risk of developing and dying from it. Exercise decreases the risk of dying. And we have found that obesity is linked to more aggressive cancer. So if there's something that you want to do to try to lessen your risk, then proper nutrition and exercise are important. Now, a study was done a few years ago in terms of ejaculatory frequency and prostate cancer. 2 studies I'll cite here, one from Harvard in 2004. And it's a men who tend to ejaculate 21 times per month, so a 20% reduction in the incidence of prostate cancer. Another study a year before, the Australian study, gave a similar finding that men who ejaculated 7 times per week saw a 36% reduction. However, more research is needed in this topic. Now, how does prostate cancer present itself? Unfortunately, when it is early, you usually have no symptoms. When it's advanced, you tend to have symptoms, but these symptoms are not specific for prostate cancer, meaning other conditions like even benign growth of the prostate can result in some of these symptoms. So you may have difficulty passing the urine, which means, you may be straining to pass the urine. You may be passing urine very frequently, getting up a lot at nights to pass your urine. Or you may find that you have developed urinary retention in which you can't pass the urine at all. I've seen patients with blood in the urine or in the semen. lower back pain. And prostate cancer, when it's advanced, has a propensity to spread to the bones, particularly the bones in the lower back. Can also spread to the bone in the hips and also the bone in the ribs. You may also have a dull pelvic pain, unexplained weight loss, and you can have weakness in the legs, and it may culminate to paralysis of the legs. And this is because prostate cancer affecting the spinal cord compresses it and result in the symptom. Now, in terms of the rationale for early detection and or screening, one, it increases the detection of early cancer. And prostate cancer tend to be curative when detected early. Another thing is that we don't have any effective cure for advanced disease. Now, for screening for prostate cancer, who do you screen? The age of the man is of course a factor. If you are above average risk, and by above average risk, I'm talking about, are you of African descent? If you are, you're above average risk. Otherwise, if any family member has prostate cancer, you're above average risk. If anybody in your family has ovarian, breast, colorectal cancer at some point, you are above average risk. And it's recommended that those above average risk start screening at 40 years. Okay? If you find that you're not in this category, then the recommendation is that you start anywhere between 50 and 55. But I find that most men in our population are above average risk and should start screening at 40 years. Now, once you start screening, what's the interval for testing? And again, it depends on your risk and the initial PSA. And you can repeat the PSA anywhere from annually up to 3 years. I've seen a study that says patients who are very, very low risk, you can do it up to 8 years. But in our population, I would say from annually to 3 years. Now, when should we recommend that men stop screening? Because all the organizations have some recommendation about at what age screening should end in men. The American Urological Organization says 70 years. However, life expectancy is important. And generally, if you have at least a 10-year life expectancy, you would have to have at least a 10-year life expectancy to benefit from the early diagnosis of prostate cancer. That's the rationale they use. However, I find that, if you're motivated, regardless of your age, and you're healthy, and you request screening, and you go to your healthcare provider, it should be allowed after discussing with your healthcare provider. Because I've seen men in their late 80s actually dying from prostate cancer. So what are the tools for screening? Okay. And we all know about the prostate-specific antigen blood test. Okay. Another tool is a digital rectal examination. Now, recently, there's been a lot of discussion about the digital rectal examination worldwide and in our population. And I will address that shortly. But in terms of the PSA, what we consider normal PSA is from 0 to 4. But not because your PSA is elevated means that you have prostate cancer, because other things can elevate your PSA. And one of the more common things that does it is benign prostate hyperplasia, or benign growth of the prostate. And as men age, the prostate tends to get a bit larger. You know, that is the price we pay for aging. Urinary retention, if you find that you develop urinary retention, your PSA can also be elevated. If you have a urinary tract infection, the PSA can be elevated. Also prostatitis, meaning an inflammation in the prostate. If you ejaculate, your PSA can be elevated. That is why when we're asking men to do a PSA, I usually say, don't do it within 3 days of ejaculating, all right? Any instrumentation of the urethra passing a catheter will cause a PSA to be elevated, as well as very strenuous exercise. Bicycling and very, very strenuous exercises can increase your PSA. Now, the digital rectal examination, I mean, the prostate is located in such a position that it can be palpated by a finger, by a glove finger in the rectum. So, and the prostate cancer tends to form in the outer part of the prostate, what we call the peripheral zone of the prostate. So, you know, the digital rectal examination at times is suited to palpate abnormalities in the prostate. So coming again, the digital rectal examination, you can roughly assess the size of the prostate. I mean, if a prostate is extremely large, you can pick that up. The presence of nodules, which may indicate malignancy. We look for the consistency of the prostate. We can find out whether the prostate is tender. You know, when you touch the prostate, the man tends to jump. You may also identify anal or rectal lesions by just doing the digital rectal examination. In fact, you know, I remember once that I actually diagnosed a rectal lesion, and the gentleman turned out to have rectal cancer. And this was just, you know, by trying to palpate the prostate. Another thing is that some poorly differentiated cancer does not produce as much PSA. And we realize that the digital rectal examination has been a barrier for some men to present due to fear and due to the invasiveness of the procedure or the examination. Now, recently, you know, persons have found that the digital rectal examination is not deemed as sensitive a tool when used to screen prostate cancer. And let me be clear, we're talking about in the realm of screening, that is men who don't have any symptoms. If you come passing urine frequently, and you know, if you're having back pain, that is not screening. Screening is when a man does not have any symptoms and present to his doctor and say, Doc, can you check my prostate? Now, as a result of this, a number of organizations have recommended omitting the digital rectal examination as a screening tool. Example, the American Urological Association. But interestingly, looking on their site, I mean, there's the American Urological Foundation, which is a foundation of the AUA. They still have the digital rectal examination on their site in their latest recommendation. Other organizations still use it as a part of their screening guidelines, including the European Association of Urology and the National Comprehensive Cancer Network. So the consensus of not doing the DRE is not universal, as it can still give useful information. But the takeaway point is that don't let the digital rectal examination prevent you from presenting. If you desire not to have it done, you know, you can opt not to have it done, and we can still do other things to screen you. Now, examination, the MRI or prostate, call it the multiparametric MRI of the prostate. I think it has, it's a refreshing evolution to prostate cancer. Prior to this, we did not have any efficient way of imaging the prostate specifically for prostate cancer. I mean, the conventional ultrasound did not do it, but now we have, and in terms of, with breast cancer, you have your mammogram, but prostate cancer, there was no effective way of imaging the prostate. You would have an elevated PSA and we say, hey, let us go and biopsy. But now, the advent of MRI, it can give you a sufficient means of saying, yes, there's a high chance that you have prostate cancer in that area of the prostate or in that area of the prostate. So I think it's becoming a game changer, and a lot of organizations are including it as a first-line investigation. So as I said before, prior to MRI, no reliable imaging modality for early prostate cancer. And if the MRI is negative, if you do the multiparametric MRI of the prostate and you find it to be negative, you can avoid doing up to 30% of prostate biopsies. And I think that is significant. It also allows for men who they see a lesion, you still have to do the biopsy. It doesn't take away doing the biopsy, but it can pinpoint, it allows you to target the area where the suspicious lesion is to biopsy it. And they do this by combining, because we still use the ultrasound to biopsy, they combine the MRI image to the ultrasound, and you're able to go and pinpoint that lesion to biopsy. But as you know, with prostate cancer, we don't just go for a lesion, we also do representative biopsies in all areas of prostate. The issue with MRI is that it's a bit costly at present, all right? But I'm seeing some positive development, particularly in the Bahamas, which may bring down the cost such that a lot of men may access this imaging. So organizations such as the European Association of Urology and the National Institute for Health Care Excellence recommend offering MRI as first-line investigations in their guidelines. Now, having a high suspicion for prostate cancer, then we have to do a biopsy of your prostate. And the biopsy involves, you can either do it from the transrectal route via an ultrasound, or you can do it via what we call a transperineal route. The transperineal area is the area just below the scrotum and above the anus. It still is done on the ultrasound guidance, but you go straight through the skin into the prostate to biopsy, to get your biopsy. And if you are found via biopsy that you have, that it comes as, it shows up as prostate cancer, the next step is to stage the cancer, meaning, is it early, or is it advanced, or has it spread to other areas? All right. If you're low risk based on probably a low PSA, or the biopsy shows what we call the Gleason score, shows certain low risk features, you may not need any further imaging. And treatment is just guided to the prostate. If it is late, based on a higher PSA or certain unfavorable characteristics of the biopsy, then we'll do imaging. And the imaging may range from bone scan, abdominal CT scan, a whole body MRI, or a PET scan. So I mean, the treatment of prostate cancer, it can be pretty costly. Now, what are the treatments available for prostate cancer? One of them, Lois, is what we call active surveillance. Now, active surveillance means that we essentially closely keep an eye on the prostate to make sure that it does not advance or develop. You know, you must have heard that a lot of men who may have prostate cancer die from other causes apart from prostate cancer. And the thing is that certain prostate cancer we know are what we call indolent and not life-threatening. And men may have it, it doesn't bother them, okay? So, I mean, men with, as we do this in men with low-grade cancer, elderly men, or even some young, some not so elderly men, can be candidates for active surveillance. So it is closely observed for any progression, and we treat if progression occurs. And we do PSA, and the digital rectal examination is still there, and possibly repeat biopsies to see if there's an upgrading in the grade of the cancer. And you know, the treatment for prostate cancer, unfortunately, may lead to some side effects. You know, and active surveillance, you know, tend to try to avoid these side effects. Another treatment option is observation, and it's different from active surveillance. And observation means you know, there's less regular testing. You aim at treating the symptoms if they arise. And we usually do this in men with who have short life expectancy from other causes, and also men who, yes, some men who say who do not wish treatment or cannot have treatment. There was a study done once that says did an autopsy of men who died from causes apart from prostate cancer. And they found that the prostate cancer detection rate in these men who had prostate cancer but didn't die from it are 30%. They found 30% of cancers in men in their 50s and up to 70% of cancer in their 70s. So, you know, you may have men harboring cancer around, and it may not affect them in their lifestyle, hence the rationale for active surveillance. Well, so there are certain other cancers that are quite high risk, and for early prostate cancer, there's surgery, and there are different ways of doing it, be it robotic, laparoscopic, or open. Radiation therapy is also an option, and you can have external beam radiation or brachytherapy. Brachytherapy means you put certain radioactive seeds in the prostate to kill the cancer cells. In terms of treatment for advanced or metastatic disease, we have hormonal therapy. And the hormonal therapy are the anti-androgens, you know, and you know, you may have heard of bicalutamide is one of them. Again, recently there has been a spurt of other types of anti-androgen. We call it second generation anti-androgen for advanced disease. And it is estimated that it can advance your life expectancy by a further 30%. The issues with these secondary generation anti-androgen is that they are very expensive. And we're hoping that the cost will go down with time. It's not unusual for a 1-month supply to be anywhere from about $4,000. Of course, there's the injection. They have to call it LHRH injection, the Zoladex injection. And, you know, even though it's not done as frequently, but orchiectomy, removal of the testes, is still a good option for treating advanced metastatic prostate cancer. Chemotherapy is also one of the treatment options for advanced metastatic disease. Now, there are other treatment options, some FDA approved for early prostate cancer. And they include HIFU or high intensity focused ultrasound, cryotherapy, where they freeze the prostate to kill the cancer cells. And there's a lot of prostate cancer. There's a lot of evolution occurring. I mean, they are now talking about focal therapy, where you just treat part of the prostate and not the whole prostate. Unfortunately, with treatment come certain side effects. And in terms of for early disease, you can have incontinence, be it with surgery or even radiation to a lesser extent, and erectile dysfunction. But erectile dysfunction is going to be dependent on your age, your prior function, and the stage of the disease. But there are strategies. The good thing is that there are strategies exist to manage these side effects, including physiotherapy, medications for erection, or even surgery. The hormonal therapy do have their side effect also, including hot flashes, loss of libido, fatigue, weight gain, and mood swings. It's important throughout the treatment that you maintain a nutritious food intake and exercise and do some exercise as needed. Now, genetic testing, not quite prominent or not quite widespread here as yet, but it is another area that is blossoming in prostate cancer. So what with the genetic testing, with the germline testing, if you have a family history of prostate, breast, ovarian, or intestinal cancer, you can test for the BRCA genes, BRCA1, BRCA2 gene. And if these genes are positive, it means that you should undergo early testing, and as well as possibly, if you find a BRCA2 gene, you may not be a candidate for active surveillance, but for early treatment. If yourself has very aggressive metastatic cancer occurring at a relatively early age, then germline testing is also good for you. It will help with your relatives, your siblings, to help to protect them. Also, if you have a high-grade cancer, and in fact, any other cancer, because gene mutations occur in about 20% of patients, and it helps to enable earlier screening or to tailor your treatment. So, as was said before, you may be able to tailor your treatment. You want to know whether your cancer will grow slowly or spread quickly, or is it best to do active surveillance or treat? Another aspect of genetic testing just requires saliva or blood for testing. Another aspect of genetic testing is actually to test the biopsy of the cancer. And again, you're able to tailor your treatment depending on this risk. And again, let me say that some cancers are very indolent and may not affect you, sparing the effects of various treatment options. So if I were to give some take-home messages, I would say, well, prostate cancer is the #1 cause of cancer-related death in the Caribbean and in a lot of other countries. Early prostate cancer is without symptoms. So don't wait to say, hey, I'm feeling fine, I'm not feeling anything. Why should I go to get tested? Early detection provides the best chance for cure. Consider checking on your prostate at age 40 years. And things to try to mitigate or lessen your risk for aggressive disease: consider proper nutrition, I mean, that proper nutrition and exercise is factored in all cancers. Consider improving with proper nutrition and exercise. Okay. So I thank you for allowing me again in your space to discuss prostate cancer. Thank you very much.